Yeah. Good afternoon, everybody. My name is Karen Humphreys. I'm one of the CHÉOS scientists here. It's indeed a privilege and an honor for me to introduce our very distinguished speaker today. Our speaker is John Spertus. He is a cardiologist and health services researcher and the Lauer, Missouri Endowed Chair and Professor of Medicine at the University of Missouri in Kansas City. Dr. Spertus has devoted his career to improving the quality of cardiovascular care, and his research focuses on methods for assessing patients' health outcomes, measuring healthcare quality, and using information technology to guide medical decision-making. And he's done some really amazing and innovative work, and we're really fortunate today to have him come and share some of his work with us. Please join me in welcoming Dr. Spertus.
Well, thank you very much, Karen. It's a real privilege to be here. And I must say, I want to be a CHÉOS scientist. I mean, that is a great acronym. Before I go too deep into this, I did want to be very transparent about my disclosures, which, a lot of what I'm going to be talking about is what I've really spent, my whole career studying. It's actually a more diverse talk. I was originally told I had 2 hours to talk, and now I'll just talk really fast for those 2 hours. But I have been very involved in developing the infrastructure to collect patient-reported outcomes, including symptoms, function, and quality of life. I've been very involved in developing decision aids and have been sort of very transparent about my realization that, when you do grants, and I'll share with you some of our grant work, to try and come up with novel strategies to improve care, and it works. What do you do when the grant ends? And it's been a real difficult thing to figure out, how do you disseminate something that you think is really helpful to patient care across the country, which is really what my sort of career ambition to do is. And you just can't do it from grant to grant. You can't even sustain a successful intervention at one hospital when the grant ends if you don't spin off a commercial entity to be able to do it and sustain it. And so Health Outcome Sciences is that commercial entity that has taken off. And now that we've taken on some investment funding, I don't have very much of a financial conflict of interest anymore, but I do have a very substantial philosophical conflict of interest. So today I really wanted to talk about how, we talk about patient-centered care. It's been in part of the IOM report. How are we really going to get there? And how can we start to move things forward to create more value in the healthcare system? And, value is really, this is albeit a slightly simplified equation of what value is, but it's about trying to improve the experience patients have in getting care and working within our healthcare system. It's about improving the quality of care and outcomes that we deliver and doing it at a lower cost. And a lot of what patient-centered care is achieving many of these kinds of aims. And I'm going to walk you through each of those components, at least in how I envision things unfolding. And I will say that as I build this story, one of the things that's even more challenging to me than coming up with tools to help improve value in healthcare is figuring out how we are going to be able to reliably and consistently do it in each and every patient. And this is a much more difficult challenge than I ever really sort of thought would exist when I started down this road quite some time ago. So the goals of my talk are to try and provide some insights into the measurement and use of patient-reported outcomes data. And I'm going to step back a little bit and give a little bit more methodologic insight about how important these tools could be, because they capture the patient's voice about how a disease affects them and their quality of life. And if we don't value that, then it's very hard to have a patient-centered healthcare system. And I'm going to try and build the case that we need to start integrating this in routine workflow in the way we care for patients so that we systematically record how they're doing so that we can use that as a foundation for treating them more appropriately, but also as an opportunity for future research and opportunities to develop more patient-centered insights into the outcomes of alternative treatment strategies. Then I want to talk about sort of what we've been doing to try and personalized care in clinical practice. And this is a very exciting and interesting area that we've been doing. A lot of my conflicts arise from that bullet point. And then finally, how do we integrate the two so that we can start to realize a healthcare system where we actually engage patients in shared medical decision-making so we can start selecting therapy that is optimized to the goals and values of those individual patients. So the treatment goals, and I'm going to shift with almost reckless abandon between coronary disease and heart failure and other areas because I think it is important that these domains transcend many diseases, and also some of my best examples come from different disease states. But in heart failure, and this would hold for many conditions, what are we really trying to do when we offer treatment to patients? I mean, on the one hand, we want to modify the progression of the disease or arrest it and try and prevent complications like arrhythmias or heart failure exacerbations and admissions or mortality. And the other major goal is actually to improve patients' health status, their symptoms, their function, the quality of life. And, sort of simply put, we're either trying to make patients live longer or feel better. And I have gotten increasingly sort of disillusioned with the concept of surrogate endpoints and altering LV strain or filling pressures or this or the other. I mean, these are sort of really what it gets down to, what our patients care about, what we need to be directing our therapy to both be most impactful for. And yet, as scientists, we seem to systematically minimize the importance of patient health status. And so this is an example of a heart failure trial. This is actually a meta-analysis of all the heart failure trials of ACE inhibitors. And what is very evident in this kind of work is that there is a very significant reduction in mortality that was highly statistically significant for those on ACE inhibitors in dark lines versus those on placebo in the dashed lines. But when I look at data like this, as compelling as it is, I start to realize, this axis only goes from 0 to 40%. In reality, if you look at a 0 to 100% axis, it is true that there is a really significant difference, and just as statistically significant as it was in the prior slide. But as a clinician and sort of a common sense person, my question is, at 2.5 years, what's happening to the other 75% of the patients that are still above the ground, right? I mean, why judge a therapy only on the minority of patients who die or don't die and not on the majority of patients who are alive? Are they doing really well? Are they doing really poorly? That should be a very important way in which we start to think about the benefits of the treatments we're offering our patients, and ultimately in counseling patients in how to think about what treatment they want that can maximize the outcomes they most care about. And so, when we think about measuring quality of life, we want to understand, we want to convince our clinical colleagues that this is important. I mean, it is something that, because it comes from surveys, it seems squishy, it seems soft. It's not like a robust, hard number like you get from a V.02 or an echocardiogram or something like that. And yet, it's important to realize how much patients care about their quality of life. And this is a very interesting study. It's a small study. Eldrin Lewis, who's a advanced heart failure cardiologist at the Brigham and Women's, took 100 consecutive patients, 99 consecutive patients in his clinic, and he gave them something called the time trade-off, which everybody know what the time trade-off is? So the time trade-off basically says, if I had a magic pill here, and you could take this pill, and you would live 9 years in perfect health, or you could not take the pill and live 10 years as you are now, would you take the pill? And if somebody's really debilitated, they say, oh, I'd rather live 9 years in perfect health than 10 years like I am now. Sure, I'll take the pill. And you joggle back and forth until you find, then you say, well, if you could live only 1 year in perfect health or 10 years as you are now, would you take the pill? And if they say, no, I'd rather not take the pill, then you go to 80%. You try and find some opportunity where they are equivalent. I am 75% likely to take the pill, I may or may not take the pill, then their quality of life is considered to be 75% of perfect. And so the numbers go from 0 to 1, and each fraction is a percent of perfect health. And when he interviewed these 99 patients, this is the distribution of scores he got. So there are a lot of patients in his clinic who would, almost half, would give up no time to be in perfect health compared to the way they are now. But importantly, a quarter of his patients would give up over half of their remaining life if they could live that shortened life in perfect health. I mean, people care a lot about being debilitated and being very symptomatic and having poor quality of life, and will give up a lot of the quantity of their lives to achieve that better health status. And so patients are coming to us to be relieved of their symptoms and to have their quality of life improved. And we have to acknowledge that we can measure this, and we should be seeking to measure it. And when I think about sort of the trajectory or how health status evolves, there is unquestionably an underlying disease process. In the case of heart failure, it's myocardial injury and neurohormonal activation and LV dysfunction, be it systolic or diastolic. And that's the underlying pathophysiology, and that's what we as scientists tend to value most and pay most attention to. But our patients, frankly, are completely unaware of what their neurohormone levels are. They're completely unaware of their BAP, if their EF is 12% or 62%. They just don't know. What they know is the symptoms they experience due to their heart failure of fatigue, dyspnea, and lower extremity swelling. They know the physical and emotional and social limitations imposed by those symptoms, and they understand how it impairs their quality of life. And, you know, I've taken the stance that you really have to measure all these domains differently, because you would treat people very differently at different aspects of their overall health status, which is sort of the sum of all of these three domains differed. So, for example, you can imagine that, you know, there might be patients with, you know, an elderly patient might be very symptomatic, might get symptoms climbing a flight of stairs, and yet because they're retired, they don't really climb upstairs that much, they actually have a very good quality of life. Conversely, you might imagine a very young laborer who has the same amount of symptom limitations, the same amount of functional limitations, but because they're sort of a manual laborer, their quality of life is dismal because they expect to be able to do so much more. And as a clinician, you might choose different therapies for different people depending on how those domains differ. And so it's nice to try and measure those independently to understand what you're going to do differently for different folks. And, you know, we've spent a long time working on creating a way to systematically measure through a simple questionnaire patients' health status. And this is the Kansas City Cardiomyopathy Questionnaire. And it essentially asks those things that an experienced clinician would ask in a routine clinical visit. You know, how limited are you in doing physical activity? How many symptoms and what kind of symptoms are you having? Are you having trouble getting around and visiting friends and family? Do you know what to do if your symptoms get worse? How's your quality of life? I mean, these are what we ask in routine clinical care. The nice thing about this instrument is that it asks the questions the same way every time the patient is contacted. So there's a reproducibility, consistency in asking this, and it isn't as good as the best clinician on their best day. You know, I mean, it clearly is not, but it is still able to do a very good job documenting the impact that heart failure is having on patients. And, I sort of think about it as a standardized history. You know, we, used to spend an enormous amount of time on physical examination by listening carefully to the heart, feeling the palpation, where the LV apex was, percussing the diameter of the heart. And, through that, in the carotid upstroke, we would get a sense of what the cardiac function was like. Then along came the echo and created a much more reproducible way of looking at cardiac function that, now creates much more consistency in following LV function across time than individual examiners. This is not as good as an individual physician taking a careful history on their best day, but it does provide a similar, consistent way of assessing across operators and over time how a patient is doing. And so I want to spend some time talking about why I think these instruments work really well. First, they capture all of the domains. So these are different subscales of the KCCQ, but they directly capture the symptoms due to heart failure, the physical and social limitations, the quality of life, and it can create summary scores to integrate all of those domains. And for most of the talk, I'll be focusing on the summary score, but it really represents the way the disease manifests itself to patients. And these things are often criticized as being soft or squishy. And this has become my pet peeve, because Alvin Feinstein, who's a very famous clinical epidemiologist, basically said, what is hard data? I mean, hard data is data that is reproducible. If you test it over and over again, you will get the same answer. And that's what hard data is a consistent measurement over time when the patient hasn't changed. And this is a way of looking at consistency of different tests. And so this is the consistency of the KCCQ 3 marks apart, and it's got an interclass correlation coefficient of 0.9, which is assessment of variability. 1.0 is perfect, 0 is completely erratic, 0.9 is very good. It's about the same as V.02, which is a physiologic assessment of bodily consumption of oxygen in the very best labs when done one day apart. It's more reproducible with 6-minute walk than physicians guesstimating heart failure status with the New York Heart, than treadmill duration. And, we still diminish this as not being hard or valuable data. So I want to just contrast this kind of performance with something that everybody would unequivocally say is hard data, which is the coronary angiogram, right? So the coronary angiogram is very hard data. And, you see these beautiful pictures, you can estimate the stenosis. And so this study was published at the end of this year. There's actually another study very similar to it coming up in CCI, and we published a different study earlier in 2013 looking at the interpretability of the angiogram. And this was a very clever study. So they took a bunch of interventional cardiologists, about 500 of them, and they gave them pristine images. I mean, carefully selected, beautiful images where they knew they got to see the coronary angiogram, and then the investigators knew by QCA what the percent stenosis was. And they had IVUS and FFR in both of them. So they basically asked the doctors, what is the stenosis? And then, do you need anything more to intervene on this lesion? And if so, do you want FFR or do you want IVUS? Very simple study. And it was all done on the web. It was, very, very cleverly done. So let me just show you these results. I mean, these just blow my mind. So, I talked about the squishiness of PRO data. So this is a complex slide to work with. So they had 5 cases. They had, 20 segments or however many segments those are. And I just want to walk you through one segment, right? So this is the patient one of their vessels, and in red is the true stenosis. That's by QCA. This was a 30% stenosis. All these little dots here, this is what the doctors thought the stenosis was. And there are a bunch of them who thought this was a highly significant stenosis, not 30%, but 90%, 75%, 80%. And in fact, about half of them said, I'm not sure about this. I'd like to get some other imaging, FFR or IVUS, to look at this lesion better. But half of the doctors said, I don't need anything. I'm just happy to go ahead and dilate that thing. It was a 30% stenosis. I mean, here's another stenosis that's, clearly critical. And yet, it's all over the map with lots of doctors saying this is not significant. So to say that PRO data is not hard data, but the coronary angiogram is, to me, is a hypocrisy that I can almost no longer stomach. And it's a very interesting challenge. And so if you had something like, a PRO, a patient-reported outcome measure, how could you use that in clinical care? Would this be a useful test over time that we could be looking at? And so if you think about the pathway of a heart failure patient, they tend to not be diagnosed, and so they're doing fairly poorly. They get diagnosed, and then they get better, and then for some period of time, they actually are, quite stable. They may have a little dip here or there. Then there may be an undulating course of decompensation with heart failure admissions, ultimately getting to sort of a very, very sick state where you could either think about left ventricular assist device and transplant and go back onto your stable course, or, ultimately they die. And how could PROs, if we were to adopt them in routine clinical care, be useful in helping us care for our heart failure population? Well, to me, you could start to think about using it to guide, risk, to guide initial management, identify patients' risk. Who are you to be more aggressive with, who less so? You could use it to document the improvement of your initial interventions or to monitor over time how patients are doing. You could use it to prognosticate, who's really likely to deteriorate significantly in the near future, and I want to be sort of proactive to prevent an unnecessary hospital admission. Or patients who are really sick, how do I recognize somebody who's really sick who I want to think about either sort of LVAD, transplant discussions, or palliative care? All of these are scenarios where I think PROs could have a very important role. And so if we sort of start with the first one, guiding risk management, I'm just going to zip through all these applications following a very sort of simple conceptual way of what a risk model is. And a risk model is basically that there are some variables that you think are going to predict some outcomes. So these are the predictor variables. So, beta 1 is the weight of the variable, X1 could be gender, X2 could be diabetes, X3 could be LV function, whatever. And you're ultimately trying to predict some outcome that is either very important to patients, or if you knew that risk, you would do something differently with the patient's actionable information for you. And so, if we take this generalized model and we say, okay, do just a score on the KCCQ predict mortality and readmissions? And we actually looked at this in the Everest study in patients a month after decompensated heart failure. And what we found in a fully adjusted model is that the strongest predictor of death and rehospitalization turned out to be patients' KCCQ scores, where compared to those with a score of 75 to on this scale, there was a 50% increased risk of death and rehospitalization with those of a score of 50 to 75, a doubling for those 25 to 50, and a threefold increase in those with a score less than 25 after you adjusted for age, diabetes, gender, and all of these characteristics. So this is an independent association of health status with subsequent outcomes. You could look at health status and costs. Is there an association? And in the same study, we found that, compared to patients with a score of 75 to 100, over the next year, those who had a score of 50 to 75 had 50%, 45%, or twice as high costs in a fully adjusted model that adjusted for all these things. So health status, independent of everything else, is strongly associated with survival, readmission, and costs. We could think about sort of other applications. And so with that information, you might treat a very high-risk patient very differently than a very low-risk patient, a very expensive patient very differently than a patient who's likely to be less expensive. Looking at changes in time, how do you interpret a change in score? And how do you know if I give the score to somebody over time, I'll get the same result if they're really stable, but I'll get different scores if they get better or worse? And so we did a very clever study. This is a long time ago. We did this study now, but we didn't know what a change in score meant. We have a good sense if somebody has a blood pressure of 180 over 110, that dropping them to 120 over 80 is a very good thing. But we had no sense about what's an important difference in KCCQ scores. So we basically took about 500 patients, and these were all stable outpatients, and we administered the KCCQ, the New York, the 6-minute walk, a bunch of tests to patients at one clinic visit, and then we brought them back 1 to 2 months later and gave it again. And then we documented all of their medicines and a physical exam, and importantly, we asked the doctors, did this patient over the last 6 weeks get better or worse, and by how much? And this was, borrowing from a bunch of the work done at McMaster to try and sort of understand what's a clinically important difference in scores. And, what we found essentially is this, which is, you just couldn't sort of fake data better than this. Until a slide I show you later, this was the favorite slide in all research that I've done. And what it shows is the change in scores on the KCCQ by whether the patient had had a large, moderate, or small deterioration, if they hadn't changed, or whether they had a small, moderate, or large improvement. And what you're seeing are very proportional changes. Patients who had a small deterioration or small improvement got about 5 points different in score, either worse for deterioration or better for improvement. Those who didn't change had no average change in score. Moderate and large were proportionately larger on both sides, such that, we now got a sense that if you change about 5 points, that's a clinically important but small change in scores. If you change by 10 points, that's a pretty large clinical change. And 20 or more is huge. And so, this is very important. So when you see things like TAVR improves the KCCQ score by 32 points, or LVAD by 27 points, those are enormous differences. When you see the difference of about 2 to 3 points with the Paradigm study, you sort of start to wonder, is that really a significant difference or not? It's pretty small, it's statistically significant, but is it clinically important? And you're starting to get a sense, and as we get more familiar and start using these more and more in our practice, I think we'll have a greater and greater opportunity to get a visceral sense about what scores like this mean. There's a very, and then change in scores can be very predictive of deterioration. This is basically saying if I adjust for baseline score, looking at mortality and readmission, which I showed you as the first slide of this, and I look at change in scores, is that important? And in fact, it turns out that about every 5-point change in KCCQ scores after adjusting for over 25 things is associated with about a 10% change in the risk of death or hospitalization. So if the KCCQ score goes up by 5 points, the hazard ratio for death or hospitalization drops to 0.90. If it gets worse by 5 points, then it goes up to 1.1. It's a very symmetric relationship between change in health status and subsequent outcomes. These changes, this is looking at the survival curves of patients who drop by 10 points versus don't, happen very rapidly. So if you're in clinic and your patient's score is 10 points lower or 12 points lower than it was the last time you saw them, not only is that a moderately significant improvement by what I showed you in the previous slides, but it's also associated with a significant increase over the next few months of that patient dying or being rehospitalized. So it's a very sensitive barometer and very useful in understanding the prognosis on a time-varying way in caring for patients. This is some of the work I'm sort of most intrigued about, and I'm going to come back to it later, which is very interesting. This is, so we have a huge problem in this country. When patients get admitted to the hospital with heart failure, we never share their prognosis with them. We never share their prognosis in clinic. I mean, we just never really talk about this. And the patient in the audience who has heart failure says, you're absolutely right. They never talk to you about these sorts of things. And so the question comes up, can we start to build a system where we can start to be proactive in engaging patients in very important discussions over time? And so the idea is, can we use scores to look at patients who, are either going to die or have a very, very poor quality of life over a given period of time? And this is work that Larry Allen did. And it was a sort of very novel study. It's a very novel endpoint. We've really run with this. We think this is a great way of thinking about it because it integrates two very important clinical outcomes. And the idea was that he took the Everest population. This is a clinical trial of tolvaptan, a completely failed drug, but included a lot of patients. And by the way, to get into this study to show how good or bad we are at measuring prognosis, to get into the study, an entry criteria was that the patient was expected to live more than a year or more than 6 months. 33% of the patients died within 6 months. And another 13% had persistently poor KCCQ scores below 45, which is sort of class 3, 4, more 4-ish, 3B4. So he said, okay, I'm going to add those together. If you either die or have terrible quality of life, that's a clinically important outcome because it's actionable. If somebody is projected to have a very high risk of dying or having a poor quality of life, then I should start thinking about referral for LVAD or transplant, or I should start really thinking about getting palliative or end-of-life care engaged. And so this is sort of, the idea is to have a flag for this. And so we created a risk model, and you can see what it does, and you can add up, the points for this, ranging from, points for being older to, up to 5 points if you have a KCCQ less than 25, and you just add up all the points. And this is the distribution of the scores of the entire Everest population. And this is the probability that they would either die or never gain good quality of life. And what you see is that about a quarter of the patients have a score of 10 points or greater using this tool. And that means that a quarter of the patients have a greater than 50-50 chance of either dying or never regaining good quality of life over the next 6 months. Now, we don't know which of those patients are or aren't going to have that outcome, but we can start to think about proactively redesigning healthcare so that if you're that high a risk, you never want to talk about this right during the hospitalization. There's a lot going on, whatever, but instead of just having them see a regular cardiology clinic, maybe there should be a separate clinic visit after discharge to start to talk about prognosis, start to understand their wishes, start to tailor your treatment strategies to the goals and preferences of that individual patient. And we're starting to embark on a program like this at our hospital. And we're hopefully the next time I get back, if I get invited back, we'll be able to report on sort of what that looks like. But it does allow us to start thinking about using health status measures integrated into routine clinical workflow and how actionable they can be. And that gets to why is it that people have had disease-specific quality of life measures for decades. It's been written about for decades that we need to be including this in the clinical care, and we haven't. I mean, very few places. I think we were talking at lunch, the Cleveland Clinic, Mass General, UPMC. There are a few places starting to integrate PROs into routine clinical care, but why has it not gotten it embraced more rapidly? And so, to me, there are 5 major reasons why this has not happened. And I sort of, to remember it, because I can never, sort of remember what I ate for breakfast, I listed it by vowels. The first vowel that we sort of have to do is actionable. When we have, a score or a tool or something or risk, you've got to do something differently if they have, a score higher or lower than some threshold. I mean, it's almost got to lead, so it's nothing from a cardiologist to know what they're going to do if the patient has an LDL of 186, right? I mean, you're all just going to write a statin. There's no thinking about that, but nobody knows what to do if the SAC angina frequency score is 48, or if the KCCQ overall summary score is 16 or 36 or 56. We need to start to think about what are we going to do differently with these scores. And we're spending a lot of time working on the interpretability of these and trying to have them linked to some other activities like the patients at high risk for dying and never getting good quality of life after heart failure hospitalization. They should be efficient. I mean, a good quality of life measure should make the physician's job easier. I sort of have this image when I was doing primary care internal medicine. I really like patient care. I really like my patients. I would talk to them for a while, and if I saw somebody coming back who had a couple comorbid conditions, and I knew they had just had, because I used to write in my notes if the patient had some life event coming up and they just went to a grandkid's graduation, I would spend my entire 15-minute slot talking about the graduation and making sure their blood pressure was okay and all of that. And literally, as they're walking out the door, their hand on the door, they would say, "Oh, doc, that chest pain stuff, that I haven't had for a couple of years, I've been getting it a lot more often now." And you're like, I just spent 15 minutes talking about your kid's graduation. I mean, I could have really focused on this. I wish you had told me that earlier. And so the idea is that if you sort of had, just like you have a blood pressure or a pulse on the chart when you first see the patient, if you had their symptoms, function, and quality of life on your chart before you even walked in the room, it would calibrate how you're going to organize your time with the patient, which is even more important in this increasingly frenetic pace that we're in now. They've got to be interpretable. We who have been developing these questionnaires, I think, have done a terrible job allowing people to understand what scores mean. And so, as an example, we're starting to think now with the KCCQ, instead of talking about it in terms of how many points from 0 to 100, maybe we need to give reference things so you could see, what is qualitatively a score range, from, really terrible to excellent. Or maybe we want to map it to something clinicians know, like the New York Heart Association classification, such that you could actually, or maybe it's the risk of dying or hospitalization. Now, this is a very simplified thing. It's not that somebody, goes from, a score of 20 to a score of 60, they go from 52% to 46%, risk of that. But it gives you an intuitive sense about how bad those scores really are. And then, we could imagine plotting a score today for what the patient's doing and putting what they were last time you saw them. And so here, you would realize that this patient had a 20-point improvement in their health status. I mean, something you did for them last time or some change they've made has led to a marked improvement in how they're doing. And so that's a very exciting patient to go see because you're going to get a lot of credit for having made them feel better. If these scores were reversed, this was last week's scores, and this is this visit's score, well, now you know they're a lot worse, and you can try and figure out why. Very much focus your exam, and it allows the scores to be more intuitively understandable, which I think is very important if we want these to be part of routine clinical care. Eventually, they're going to have to be obligatory. I mean, I would like to think that clinicians will be so excited to use these tools and change their care that it will just happen. But frankly, I just don't see them feeling like there's enough of a need to get a better history than they get now, and that this really is efficient or understandable. It's just not worth the hassle. And it is odd. I mean, to me, to collect a score, to enter it, to score it, to print it out, to interpret it, that requires a lot of cognitive effort and work. And we in the United States get paid nothing for doing all that effort. But if I get a B&P or if I get a hemoglobin A1C to look at how my patient's diabetes has been controlled over the last 3 months, not only do I get paid, $60 to $120, but I'm actually considered a bad doctor if I don't do that every year. And so the hypocrisy that we would sort of pay for a lab test, but not for all of the training, effort, and energy that goes into really understanding how patients are doing is very frustrating to me. And eventually I'm hoping that Medicare will start, doing this, that insurers will demand it, and you're getting hints of that. I mean, in TAVR, they are only paying for TAVR if you're in the TVT registry and you have to collect the KCCQ at baseline and in follow-up to be part of that registry. So it's something that might be happening, not fast enough. And then they've got to be user-friendly. These original instruments, 23 items, et cetera, that's too much, So we've actually now simplified the KCCQ to 12 items. The Seattle Angina Questionnaire went from 19 to 7. 7 items. I mean, it's one piece of paper. It takes a minute and a half for somebody to fill it out. This is the way we have to start doing it, giving it on iPads, whatever. I mean, there's a lot of creative ways you could imagine this being integrated in the EMR for docs to use, but it is now getting feasible and user-friendly to use these kinds of tools, and they preserve all of the same sort of performance metrics that we see with the full items, and we've done a lot of extensive work. So that's sort of the background on PROs. The work and it sort of reflects what I did in the first half of my career. The last half of my career has really been devoted to this, and it is trying to figure out how can we start to deliver personalized evidence-based care in routine clinical practice. And when we think about evidence-based medicine, we think about guidelines, right? We think about what are the clinical trials that lead to guidelines, and are we applying this to our patients? And what this slide is meant to do is to think about that kind of evidence, right? So we have a new treatment, and some patients will do really well with that treatment, and they're in green. Some patients will have sort of do so-so with treatment, they're in yellow, and some patients will actually be harmed by therapy, and they're in red. And we will do a study, a clinical trial, an observational registry, something along those lines, and we will find out that on average, of the good, the intermediate, and the bad outcomes, this therapy was very beneficial. And that's what you see in the New England Journal or JAMA or CMAJ or any of our journals. You see the average benefit across the population. And what this slide makes incredibly clear is that there is, in fact, no patient who has a green head, a yellow body, and red legs, right? The summary is a summary of the population's experience. When we write guidelines, what are the guidelines made of? It's a bunch of smart folks like us sitting around the room debating and reviewing and summarizing these summaries of the actual patient experience. To me, I think that's why the guidelines are really essentially flawed and dead. I mean, I'm getting more aggressive in my disdain for them, but they're very arbitrary. I mean, 3 different panels creating the stable ischemic heart disease guidelines would come up with very different recommendations of what's 2B, what's 2A, what's 1. I mean, there's a lot of gestalt in there. And where we need to be going is not summarizing these summaries of patient experience, but to actually risk stratifying our patients to find out who's going to benefit a lot from therapy, and we want to be aggressive in treating, who's going to have offsetting risks and benefits, and whom we want shared decision-making to be even more prominent, and who's going to be harmed by therapy. We could actually not treat, save money, and improve their outcomes. And that's what we need to be working towards. And so, I'm going to sort of delve deep for a minute, and you're talking about the forest, the trees. This might be getting a little bit into the roots of the trees of the forest. I mean, they're getting very detail oriented. But in angioplasty, we have lots of decisions that we make routinely. I mean, what I think is most important is on patients eligible for angioplasty, who should get angioplasty, who should get bypass surgery, who should get medical therapy. But I'm even taking that off the table. That's like a stretch goal, because that's where shared decision-making and personalized care and all that happens. But, after we decide that the patient needs an angioplasty, we need to think about what are the decisions we make reflexively in caring for this patient that could be informed by evidence. So bleeding is a very common complication of angioplasty, and there are, in fact, risk models that will show us what is the risk of this patient to have a bleeding event, and should I treat a higher risk patient more aggressively? I'm going to delve into that. The same thing holds with acute kidney injury. There are patients who are not at risk for acute kidney injury. It doesn't matter if you do multivessel angioplasty and lots of contrast, but there are other patients who are at very high risk for acute kidney injury, who it would be far safer to try and really minimize contrast and stage their procedure a month apart to give their kidneys a chance to recover, to not do an LV gram, to not, to bare wire lesions. There's lots of tricks we can do to decrease the risk of acute kidney injury if only we knew who was at high risk for acute kidney injury. This choice about drug-eluting or bare metal stents should really vary by the benefit the patient gets, given what their risk of restenosis is. Or even something as mundane as who can I send home safely for same-day discharge versus do I have to watch overnight in the hospital might be based on risk models for bleeding. And it's a conceptually different way of thinking about what registries are for. We currently view registries as collecting data to understand and measure quality. And quality is judged by collecting lots of data, building prediction models, and giving feedback to the hospitals on a quarterly basis. What is your observed complication rate versus your expected complication rate? And if it's greater than 1, you got a problem. And if it's less than 1, go forth and prosper. This is what quality improvement, this is what the ACC is built on. And to me, if you have a risk prediction model, why don't you use it at the point of care to make a decision about how to better treat that patient? And that's what sort of my conflict with this ePrism software is that we've created the infrastructure to take these risk models, allow you to import from the EMR or add directly what that patient's age, diabetes status, kidney function is, whatever, and generate that patient's predicted outcomes based on very robust risk models that have been developed throughout the NCDR. And there have been web-based calculators forever, right, to do this, but they never actually get used. So the trick is, can you integrate this, collect this, and print the information out in a way that it can be part of routine clinical workflow? And so this is where it really deviates. The Society for Thoracic Surgery was on the vanguard. For 15, 18 years, they have had surgical risk models on the web that you can enter. The only time I ever see a patient's STS risk prediction outcomes is when the surgeon does not want to operate on the patient and they want to document that they're at very high risk for a bad outcome. I never see it in routine clinical care, ever. And so our goal is to try and integrate these into routine workflow. And this speaks to sort of the infrastructure about how you develop these tools. And I really want sort of Karen and Bill and Colleen to pay a lot of attention to this slide, because this is the infrastructure where you build, shared decision-making tools based on evidence. And the idea is that you do a lot of outcomes research or clinical trials or comparative effectiveness research. You build your prediction models and you want them to improve medical decision making. There are several distinct steps. The first is to be able to deliver the evidence. Now, our group has spent a lot of time building the IT infrastructure to run the models, but you have to build the models themselves to deliver the evidence. Then you have to get doctors to use the data. And I'm going to give you some insight into what a daunting challenge that is, but it is an important one to overcome. And then you want the patients to use the data because you want this to improve patient care. And so what this requires is teams with expertise that work together. Part of the team has to be a statistical modeling team. And we have done a lot of thinking about how do you build useful and practical models. And it's not throwing the kitchen sink in. It's really trying to create parsimonious models. But when you build a model, you have to know what outcome am I building it for. And so you need qualitative researchers to work with patients and with physicians to say, what information is most important to you? How can we sort of get you the knowledge you need to make an important decision? And we had this experience where all the clinical trialists for stroke trials said, we're going to predict the outcome of modified Rankin 0-1, meaning no disability is sort of a 0-1 modified Rankin score. And when we asked the patients, they said, no, we just want to be independent. So 0-1-2 is what the patients cared for. It's a completely different model that you have to build for that. And so the statisticians have to know what is the outcome I'm building, and that has to come from the patients. And then you need implementation people to tell you what are the variables that you're even going to have available to you with which to build the model at the time that decision needs to be made. And so you get these synergistic cores of expertise where the qualitative researchers tell the statisticians what model to build. The statisticians work with the implementation people to figure out what variables to use and how simple does the model have to be and how much do I have to give up on its discrimination and predictive accuracy in order to have it actually usable in clinical care. And then you have to have the implementation people figuring out with the qualitative research how we're going to integrate this in flow and give the information in a format that the patients most understand and can work with. So I'm going to just give a really quick story about bleeding. And this is just to show you the power of these personalized approaches. So bleeding is a big deal in angioplasty. It happens a lot. It's very expensive when it happens. And our guidelines even recommend that we should assess the risk of bleeding before we do angioplasty. And it's interesting because this is actionable. I was talking about actionability with health status, but there are things you would do differently as an interventional cardiologist if somebody's at high risk for bleeding or at low risk for bleeding. And if they're at high risk for bleeding, you might use a radial approach rather than a femoral approach. You might use bivalirudin with a radial approach, depending if they're at very high risk or not. You might want to keep them overnight to make sure that they don't bleed when they go home. Or if they're at low risk for bleeding, think about same-day discharge. And the idea is that the higher the risk the patient is, the more aggressive you want to treat them. And this is a big comparative effectiveness study done on 1.5 million patients in the NCDR. And what it shows is that in green are patients that got bivalirudin, in red are patients that got heparin. And regardless of the risk of the patient for bleeding, you see that it's occurs about half as often if you get bivalirudin in green versus getting heparin in red, right? But it turns out because these low-risk patients have such a low risk of bleeding, and these high-risk patients have such a high risk of bleeding, that you have to treat almost 225 low-risk patients with bivalirudin for one not to bleed. And remember, it's $700 a vial for bivalirudin. And if you are light, it's one vial. If you're heavy, it's 2 vials. So it's a lot of money to get this drug versus heparin, which is essentially free. And so treating 227 patients with, bivalirudin may or may not be a very cost-effective use of resources, but you would only have to treat 40 high-risk patients to prevent a bleeding event. And so you would like, for patient safety reason, to see a lot more of this drug used in the high-risk patients. In fact, we costed it. David Cohen was up here last week. He's an expert in cost effectiveness. He figured out how much does it cost our hospital every time we use bivalirudin in a low-risk patient. And it actually costs our hospital $700. But every time we use it in a high-risk patient, we save $1,600 because of shorter length of stays, less transfusions, less bleeding events. So
for not only patient safety reasons, but for our own economic self-interest, we would want to be very aggressive in using bivalirudin in high-risk patients, right? Does that make sense? So in 1.5 million patients in 1,100 hospitals, this is the actual pattern of bivalirudin use. In the low-risk patients, it's given most often, and in the high-risk patients, it's given least often. This is what we call the risk treatment paradox. I mean, based on what I said, this makes no sense, right? And the reason is that because, doctors do not intuitively know what the bleeding risk is of patients. It's not like they're dumb. It's not like they're trying to do the wrong thing. They just don't know. It's hard to know because you have to integrate a lot of variables to do this. But if you could do that, you'd like to see us lower the use in the patients who don't get much benefit and whom it's costly, and to increase the use in the higher risk patients where there's a much greater opportunity to improve safety and even save money. So, what the NCDR did is they built a risk model. This is what it's like, and we basically just programmed this ePrism system with these coefficients because there's no way a doctor is going to add up all these things and put it 1 over e to the x of that sum of those numbers. I mean, it just tries to make it very simple, and we wanted to integrate it into workflow. And so for us, the best opportunity was to look at the informed consent because nobody can get on the cath lab table without signing informed consent. And our informed consents are terrible. I mean, I don't know if yours are this bad, but this is written at a 16th grade level. It says nothing. I mean, it's written in legalese. I mean, I acknowledge that no assertion has been made to me as the expected outcomes of this procedure and adverse consequences may occur that I fully accept in proceeding with this. I mean, blah, 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 blah. It doesn't say anything, In fact, we changed all of that to say, I understand sometimes things can go wrong. Our lawyer was shocked that we used the word things. I mean, shocked. Like we went around for 20 minutes before she finally relented. But it was, there was an opportunity to make this a much simpler and easier document for patients to understand. One that included pictures about what's a cath or what's an angioplasty or what's a stent, written at the 8th grade level. It's actually the 6th grade level until we had to put all the HIV disclosures in. But still. And we sought to test this. And so we did it at our center, but then we replicated it at 9 centers across the country. And, I'm not going to bore you with all the data, but it actually really improved patients' reading of the consent, understanding of the consent. They were not as anxious after reading the consent. They participated more in shared medical decision-making around stent choices. I mean, it was a very good thing from the patient experience perspective. But what I liked about, I'm all for the informed consent, but that isn't my life's work, is to do informed consent. I wanted to use this as a Trojan horse to deliver the personalized risk for each individual patient so that the doctor could know, is this a high or low risk patient, and they could start to build in protocols to support the tailoring of therapy to risk. And that's what I was really excited about. And so this is a very cool slide. What this is this is the risk of bleeding before the case. In the dotted line are the observed bleeding rates before the doctors knew what the bleeding risk of the patient was. And in the solid line is the second half of the study where the doctors knew the bleeding risk. And what you see is a marked reduction in bleeding, especially in the high-risk patients, where given these number needed to treat things I showed you earlier is exactly where you would expect the reduction to be. In fact, there in a fully adjusted model, there was a 45% reduction in the odds of bleeding when the doctors knew the bleeding risk of their patients versus when they didn't. That is a marked improvement in safety, in cost effectiveness, because we lowered bivalve use in the lowest risk patients and increased it in the highest risk patients. This is a very good story, right? And I just wish the story ended here, but I want to illuminate for you what is sort of the most exciting and depressing thing I've ever seen. And this is even worse than the variability I showed you in the interpretation of an angiogram, right? So let's look at the study. We had 137 doctors at 9 institutions treating 7,500 patients before we gave the risk estimates. And based on all the information I showed you, this is what ideal treatment would be like, right? I mean, this is the patient's bleeding risk. If it's very low, you probably don't need any bleeding avoidance strategy. But at some point, you need at least one bleeding avoidance strategy, bivalirudin or closure device or radial approach. And if they're really high risk of bleeding, maybe 2 bleeding approaches. But regardless, this is sort of the pattern you would like to see, right? At some point, everybody starts getting treated. So the ideal physician behavior is a curve like this, and everybody gets me, that's the curve you would want, right? So let me show you the actual, maybe I didn't make this clear. These are really good interventionalists, right? This is the Mayo Clinic, this is Barnes Jewish Hospital, this is Yale, this is Baylor. I mean, these are not, Wichita State community practice thing, I mean, these are serious, excellent places. These are places where your mom, if she needed angioplasty, might travel to get her angioplasty done. Let me show you what these 137 excellent interventional cardiologists, how they treat their patients by risk. Now, I just want to take a moment and just look at this with you. I mean, this is horrifying. I mean, you talk about wanting to be a high reliability healthcare system. I mean, look, some of these doctors are always using it, which may not be so bad. Some doctors absolutely never use it, which makes no sense at all. And those who are discriminating tend to use it much more in the low-risk patients than in the high-risk patients. And now, of course, you have to understand, when I'm talking to one of the interventionalists that was in the study, I always say that they are this person right here. But other than that, they're the only one who did it right. And so this just highlights the variability of care. And if your mom had a 10% risk of bleeding, which is a very high risk for bleeding, you wouldn't want her to get 1 bleeding avoidance strategy. You would want to get at least 2, right? If she saw one of these excellent doctors, her chance of getting any bleeding avoidance strategy at all ranges from 1 to 100%. I mean, this is absolutely horrific. So, this is looking at bleeding, the use of contrast by risk of acute kidney injury. Again, it's all over the map. What you want to see is this dashed line where as patients' risk of acute kidney injury gets higher and higher, upwards to 20, 25%, you use less contrast. You see no hint of that there. So we are clearly missing the mark of being highly reliable, like that first slide where all the arrows are in the bullseye. That just ain't what's happening out there. And if you look at any hospital or any region in Canada, it would look exactly the same. I mean, it is not that these 9 of the best centers in the US are somehow different than you would see in every hospital. We never look. And, it's a challenge. We've got to start looking. So, how do you go about correcting this problem? And this is sort of the implementation arm of trying to affect change. So the first thing is to deliver the risks so doctors know it ahead of time. And I didn't go into great detail on why the doctors ignored it. I mean, some really changed, and that's why you saw the bleeding reduction, but a lot of doctors didn't change. And so what have I learned about trying to improve the consistent use of personalized medicine? The first thing is that if you have a great solution, like delivering risk models and routine workflow, if the doctors don't think there's a problem, you're providing a solution for which no problem exists, and that's a problem. And so there's a philosopher who, have you guys seen this slide before? I apologize, but there's a philosopher, I just love this. And the philosopher's name is Captain Jack Sparrow. And he says, the problem is not the problem. The problem is your attitude about the problem. And one of the critical things we have to start to do if we want to create a higher reliable, more consistent, evidence-based, personalized healthcare system is creating an awareness of the doctors that they can and must improve. Second is that, this is so difficult. I mean, changing physician behavior is really, really tough. And so we have to think a lot about sort of all the obstacles and how we're going to overcome them. And this slide is a reminder. So some of you may know my wife was a physician. She gave it up. She now runs a grass-fed sheep dairy. She raises sheep. She milks the sheep. She makes cheese. And when we, sit down at the end of the evening to talk, which either I'm traveling or she's, in the cheese kitchen, it's not as often as I would like, I listened to her talk about all the problems, and you cannot believe how many problems go wrong in making cheese. I mean, the compressor was leaking, and I couldn't get a good seal on the yogurt containers. And what does she do when a problem arises? She goes and she figures out what's the problem, how do I change it, what standard operating procedures am I going to put in place so this never happens again. I mean, it's a very creative, solution-oriented approach. We have to do the same thing in trying to drive consistency in care in cardiology. And so, we need clinical champions. I mean, if there's not somebody within the cath lab who's going to take charge and view the success and change in the cath lab as their badge of honor and the failure to get their guys to change, or girls to change, or women to change, as a failure of their personal professionalism, it's not going to go anywhere. So it's a real important to do that. And I don't think we should implement these kinds of tools in a cath lab unwilling to do it and let them have bad outcomes and hurt their patients for all it's worth, because eventually everybody else will change and they'll come late to the game with their tails between their legs. You got to develop protocols. I mean, we really are, if we're going to deliver consistent care, there's got to be very clear strategies about how you respond to patients of a certain risk and to be consistent across the board. And then you've got to implement it. You've got to make it easy for the doctors to have the information. We're now sort of projecting on the cath lab monitor, what is the appropriateness use rating, because that's sort of one of the issues people have. What is the bleeding risk, which you absolutely can't see in yellow here, but it's got the green, yellow, red thing, and this is an intermediate risk patient. What is the risk of restenosis with a bare metal or a drug-eluting stent? What's the safe contrast dose? Before you even start the case, this is all up on the screen in the monitor where you're normally taking your angiographic pictures, and you can start to have an organized timeout. You can sit with your entire team instead of just saying, oh, do I have the right patient? Is this the right doctor? Do I know why they're here? You're starting to now say, what is our strategy to minimize the bleeding risk? Or when do I want you to call out to me? I'm approaching my contrast limit so I can decide to stage or not stage this case. I mean, this is a meaningful timeout. This is what we have to start working to accomplish, I think, if we want to implement protocols successfully and creatively. And it's very easy to do when you're all standing with the patient right there and looking at a monitor that has all of the information and you have the protocol posted on the wall. I mean, even a medical student could figure out how to sort of drive that forward. The last stage is to start to hold ourselves accountable. We've got to create accountability in change. So back in 2011, 12, we sort of did this work in looking at the change in behavior after our doctors knew the risk model. And we had a risk treatment paradox before the doctors knew what the bleeding risk was of the patient. We reversed it afterwards, so we had less use of bivalve in the low risk patients, more in the moderate and high. I will say that I was very disappointed when I saw this. I mean, even though it's highly statistically significant, to me, this white bar should have been 0 because why use bivalve in a low-risk patient? This should have been 100. But even this change, as small as it is, saves our hospital $325,000 a year. Our potential savings are almost $900,000 a year if we really went down to 0% and 100%. But this is where we were. And so you would celebrate if you looked at this data that we were doing better. We saved money, our bleeding rate went down by 40%, and we had better behavior. But then we looked across doctors, and what you see is that, yes, all the doctors are treating the low-risk patients less than the high-risk patients, but we still have almost a 6-fold variation in how one doctor would treat a high-risk patient versus another doctor. And so our hospital has for the physicians a proportion of their salary that's in a quality bonus. And they'll set separate goals for the physicians to get that quality bonus each year. And in 2013, the quality bonus was linked to the physicians decreasing this variability across doctors in the use of bivalve in our cath lab. Now, just to give you some sense, there are 9 interventional cardiologists, there are 42 cardiologists. All 42 cardiologists' salary bonus was linked to the 9 interventionalists changing their behavior in the cath lab. And this is the 2013 data. And it actually is better than this. I mean, some of these patients, some of these doctors are experts in CTOs, and so there's a reason not to. We didn't pull those out of the denominator, but it's so obvious how much better the performance is there. And in fact, our predicted bleeding rate was 6.5%, and our observed bleeding rate was 2.4%. I mean, this is a really good example about how you change physician behavior, improve safety and outcomes, and that change in behavior is worth another $160,000, so about almost $500,000 a year savings compared to how we were treating patients per year before that. I mean, that buys like, 4 or 5, STEMI nurses. I mean, it's a big deal for our hospital to save that much money. This is another hospital that focused on AKI. And in 2012, they were using about 245 cc's a case. It went down through 2013, particularly in the patients at highest risk for acute kidney injury. And this is what happened to their rate of acute kidney injury. It went from 8.5% to 3.8%. It's now below 3%. This is a remarkable improvement in safety and a remarkable savings. They estimate almost $900,000 a year of savings to their hospital just for AKI avoidance, which seems a little high to me. So how are these trends going to converge? How are we going to take PROs? How are we going to take individualized medicine? And how are we going to try and bring these together? And, my feeling as an outcomes researcher is that we've spent too much of our profession's energy in describing problems. And we haven't spent enough on solving them. And we have got to move from description to action. And, these kinds of things about don't tell me, show me, I mean, I see this every day. Every day I'm reminded that, it's not what you describe and talk about, it's what you actually do. And that's because I live in Missouri, and we have it right on our license plate, the show me state. This is not about sort of talking, it's about really making change and achieving what we all theoretically went into medical school to do. So, there's a lot happening too. I mean, this is from earlier this week. President Obama in the State of the Union described the Precision Medicine Institute. Tell me if this resonates with anything I've talked to you about now. Most medical treatments have been designed for the average patient. As a result of this one-size-fits-all approach, treatments can be very successful for some patients, but not for others. This is changing with the emergence of precision medicine. I mean, this is where the puck is going. And outcomes, I said that for you Gretzky fans, This is where the puck is going, and this is where we in outcomes research are perfectly poised to take advantage of this incredible opportunity, and we've got to do it. And so, we talk about sort of quality improvement being this kind of distribution of performance where some providers are very poor, some are very good, and, this is the average. And what we do is we sort of measure and we improve and we hold people accountable and we shrink the variation and we shift it to the right? That's quality improvement. And that's sort of never been demonstrated more than in AMI care. So this is acute myocardial infarction care. The dark bars are the use of the 30-day risk standardized mortality across hospitals in 1995. This is in 1995 and 2006. And what you see is that there was a lot of variation in survival across hospitals in the United States. It got a lot tighter in 2006. The average rate in 95 was 18%. It was 15% in 2006, meaning that because of all the work we did to improve the consistency of care across hospitals, for every 33 patients who had a heart attack in 2006, one of them would have survived in 1995. That is a remarkable benefit. And so it sort of suggests that all quality improvement is around narrowing the distribution such that you have a wide distribution of performance before and it narrows afterwards, right? But actually, it has to do with what is the source of that variation. So if you're really giving patient-centered care, and then before is treating everybody the same because the physician felt like that's the way they should be treated, and after is seeing wider variation how patients are treated because they have different goals and preferences. And so you want to support shared medical decision making, which is essentially the idea that the physician explains there's a choice of treatment, and there's an information exchange between doctors and patients such that, the physician can educate the patient about what is the disease, what are the treatment options. The patient can then say what are their preferences for care, and then they can discuss what's best, make a decision, and then revisit that decision over time. The problem in this paradigm of shared decision making is that the patients really want to know about how are they going to be feeling after treatment with one treatment versus another. What are their symptoms? What's their function? What's their quality of life? And clinicians have no idea how to present that information. We don't know how they're going to be doing because we don't measure it. We don't have risk models for these outcomes. So how are we supposed to share the information that the patients actually want with them? So, we have been working on this. So there is enormous variation in care, right? I mean, this is a decade old, 2 decades old now. It doesn't change. There's a tenfold variation in our country in the use of PCI. And it's because this is an example of a very typical patient, right? This 72-year-old diabetic comes in with 2-vessel disease. If she sees a general cardiologist like me, she's going to get anti-anginal medicines. And if her angina goes away, then I'm fine. If she still has angina, then I'm going to refer her to revascularization. If she sees an interventional cardiologist, she's going to get angioplasty. And if she sees a surgeon, she's going to get surgery, right? That is remarkable variability in care, not at all due to the patient, but due to the operator and their preconceived biases. What if you could share with a patient like this, here is the survival in a year with bypass, angioplasty, and medical therapy for somebody like you. Very little difference. Here is the difference in angina. The likelihood of having any angina in a year, and this actually comes from Colleen's data. The likelihood of any angina is, maybe 95% angina-free with bypass surgery, 93% free angina-free with 93% with bypass surgery, 88% with angioplasty, and 82% with medical therapy. So the angina control's a little bit better. Even though 82% of the patients treated medically actually have no angina a year later, they may say, well, I think I'd like bypass surgery, or I'd like angioplasty. Well, then you can say, well, what are the risks you have to endure up front in terms of major adverse cardiac complications for those benefits? And, there is no right or wrong here, right? I mean, this is an opportunity for the patient to say, is it worth it having a major complication like death or stroke or heart attacks for this amount of angina relief? It may well be. Or maybe they'll say, well, let's try medicines, and if I don't feel well in 3 months, then we'll go to revascularization. This is the art of shared decision-making, is creating these personalized models based on that patient's individual characteristics and presentation. TAVR is a very interesting example. This is sweeping interventional cardiology. I mean, this is the cool. Anybody do TAVR here? No. This is the cool thing, right? I mean, and that means that none of you are cool. And, it is very clear that some patients just don't do better with TAVR. I mean, and hospitals are losing their shirt on this in the United States. I mean, it is very expensive. We lose money on every TAVR procedure we do. And the thought is that, can we use the data? So this was our core one activity in creating a shared decision-making tool for TAVR, where we built a prediction model of the likelihood that the patient would either would survive and have an improvement in quality of life at 6 months. So it's that combined endpoint concept. And the idea is that we called a poor TAVR outcome somebody who either died or had a terrible quality of life. And defining a bad quality of life was challenging. We actually spent a lot of time, we have a whole methods paper in Circ Outcomes on this, is what is a bad outcome? We basically considered a bad outcome to be either their KCCQ score was less than 45, which is sort of class 4 heart failure, or it got worse by 10 or more points, either of those. So the way you think about this is these are the baseline KCCQ scores in the partner trial. This is the 6-month trial, 6-month results. And what you see is even in the patients with the worst scores of 25 or less, some patients get enormous benefit from TAVR, and some patients get no benefit from TAVR. And in fact, you can sort of build this group of patients who have a bad outcome and figure out who are those patients. So they never get above 45 or above class 4 heart failure, they die, or they have persistently, their quality of life is 10 points worse on the KCCQ than before the procedure. Those are bad outcomes. And so this is the risk model. And where we are now is we're trying to build tools that will allow us to stratify risk. You can see in the low risk what the risk of death and poor quality of life is and what it is in the high risk. And it varies quite a bit. And our idea is that we could create a tool for patients that would explain it. We haven't built this yet for TAVR, but we have done this for TPA and acute stroke, where we sort of show patients, this is what's a stroke, but we'll build an educational page, very simple, what is a TAVR? What are we going to do for, this treatment? Maybe in the stroke patients, they wanted to know what the clinical trial showed. So this is the average benefit from all the stroke trials for having a normal outcome if you get treated with thrombolytic therapy or not. And then they want to know their individual outcomes. Here, it's a 77% chance of a really good neurologic outcome with TPA versus 70% without. And you have an 8% risk of a really bad outcome with or without TPA. We're going to do this for the TAVR model, but it'll give patients a sense of what are the upfront risks of the procedure for what likelihood of feeling any better in 6 months than you do now are. And I think it's going to have a huge impact. So, I'm just going to sort of end by saying that, I think the way we're going to improve the value in healthcare is start to try and deliver personalized medicine and routinely use PROs to not only sort of track our patients, not only use it for guiding therapy, but for building ultimately the models to share with patients what their expected outcomes would be so we can better support shared decision making. I think we can improve outcomes a lot by improving our commitment of tailoring treatment to risk and trying to increase the consistency of care across doctors, which is an enormous problem. And finally, I think by tailoring treatment to risk and avoiding treatment in those who don't benefit or who actually wouldn't even want treatment if they knew how bad their outcomes were likely to be, we will save a lot of money. And collectively, those three activities will increase the value of healthcare, and that's how I think we've got to get there. So thank you very much for your time, and I'd love to answer any questions you have.
Thank you very much, John, for an outstanding presentation. It was very thought-provoking as well.